Today's session is bioresorbable technologies and an evolving issue. And we have here William Wijns, course director, and Arif Al-Nooryani, who is one of the most experienced implanters of bioresorbable technologies in the world. And he had experience with many of the technologies. So William, why would you have a bioresorbable scaffold? Surely if the stent or scaffold goes away, then the narrowing will come back, won't it?
Oh, well, sometimes that's a question that patients ask.
Yes.
But by and large, patients really love the idea. So do we. I think that the dream, what used to be a dream and has now nearly become reality, to have a stent that does its job and then disappears over time, leaving nothing behind, is a worthwhile goal to pursue. Think of the longevity of the patients that we treat. A young person who receives a stent at age 35 or 40 may have a life expectancy, hopefully, of 30, 40, 50 years nowadays. And also, we know that many patients will have rapid progression. Think of patients with diabetes. So I think that permanent implants, they do the job, but the future, in my opinion, is the use of bioresorbable scaffolds and bioresorbable technologies in general.
So Arif, what materials are used to make bioresorbable scaffolds, and what are the challenges that come with using these materials to make scaffolds?
Well, so far we have two basic materials, which is the PLLA or polylactic acid, and magnesium alloy, which is about 93% of magnesium and 7 of different other elements. And those two basically are the materials being used for developing this BRS. Now, the challenges we are facing is something we have been thinking of. One is really the strut thickness. We know that the strut thickness of those BRS are much higher than the normal. It reaches 157 micrometer, and compared to other metallic one, which is about 80 or 60, even below 80. So that is one thing. The cost is another issue. We know that we are using more material during the implantation of those BRS. We need more balloons, more wires, some imaging tools, which are really a very important element and factor to improve your outcome. Besides other, for example, prolonged dual antiplatelet therapy, which adds some also more cost and some maybe prolonged risk for the patient. So that is maybe the main 3 points I can brief.
So the design of the scaffolds has to address the limitations of the materials, and this can lead to challenges in delivery, for instance. And can you tell us a little bit about some of the challenges that these designs lead to in the patients?
Yeah, one of the issues is that the footprint of the current devices is very different, in the sense that the wall coverage is perhaps twice what it is with state-of-the-art metallic DES, and also the load of material to be bioresorbed therefore is important. So a couple of statements that I think we should keep in mind. We're dealing with first-generation technology. Second, we basically have large number of trials with only one of the many devices that are currently under evaluation. I'm talking about randomized clinical trials, large registries, and medium to long-term follow-up up to 5 years. So the data is still relatively limited, but the disappointment has been that the results of the trials were not what we had hoped for. And unfortunately, there is a safety concern with respect to an increased rate of scaffold thrombosis that has emerged. I mean, it's not very high, but the risk ratio compared to patients treated with metallic DES is significant, beyond any doubt.
So the scaffold thrombosis is a very uncommon event, but it is more than with metallic stents. So
Exactly.
So how do you address this problem? What do you do to try and reduce this? Because you've told us that your scaffold thrombosis rate is actually very low. And so what are you doing to prevent it?
Very good point, John. Actually, the way that we should be avoiding this, the way we have been doing this since we started the program 2012 actually, was to implement the technique in a proper way. That means to follow the PSP, very sharp, very strict.
So explain what you mean by PSP,
Right,
please.
that is then pre-dilatation, scaffold placement, and post-dilatation.
So pre-dilatation, scaffold,
Scaffolding or stenting, what we call it scaffolding now,
Yeah,
and
yeah.
post-dilatation.
post-dilatation.
So the
yeah.
PSP should be really strictly followed, and this is one of the challenges I believe William can share me during those that the trials did not. If we go through those trials that shown some also late thrombosis, we have seen that some of those trials, this kind of those steps had not been followed strictly, and they were missing. So this is one thing we should address, that people who decide to implant BRS, then they should follow what we are advising, and we believe that that has an impact on the outcome.
So you talk about post-dilatation, but we know that the scaffolds fracture more easily. So tell us what you do to limit the risk of fracturing the scaffold.
Well, first of all, we know that the sizing of the vessel and the scaffold that being used for that vessel is quite important and has a significant impact on the thrombosis, whether it's acute, subacute, or late or very late thrombosis. So we should pay attention to use the imaging tool in a very let's say systematic, the imaging tool, which is the OCT or IVUS, whatever.
Right.
You should use, sometimes if you don't have, you use maybe QCA, but which is inferior to the others certainly. But I believe we have been, for example, using this kind of imaging in almost 90%, over 90% of our cases been assessed with imaging technology. And that was certainly having a great impact on our population or our patients' safety.
Okay, so do you think the danger of scaffold fracture is related to pressure or to size of the post-dilating balloon?
Well, we don't see that many cases, frankly. So we didn't see that many of breakage of the scaffold as much as been mentioned, maybe malapposition. That is maybe more to be discussed rather than scaffold. Pressure itself, you can go the pressure you like to. It doesn't break the scaffold. I haven't experienced a single case even having a fractured scaffold by post-dilating.
You have long-term optimism about the future of these technologies?
Yes, definitely, John. As I said, the goal is worth pursuing, and ultimately we want these devices to become mature enough to address currently unmet needs, like for instance the treatment of very long diffuse disease. But we're not there yet. I think we have to go through a process of evaluating new devices with different materials, modification of the materials, perhaps metallic scaffolds, thinner struts, so that we will be less constrained in selecting the patient and the lesion, and also we will have fewer limitations in terms of acute performance that propagate over time and are eventually the cause of the late side effects that we have seen. So we have quite a number of new iterations of existing devices and novel bioresorbable scaffolds that are being evaluated at the moment. And I think careful optimism is very appropriate. One message for the colleagues: we have a responsibility to protect the future of this technology. So let's go for very careful, stepwise evaluation, each time confirmed by adequate data, either from randomized trials or high-quality registries. And in this way, I think we'll end up in a few years with second, third, or fourth generation devices that will do the job that we want them to do.
Right. So we are experiencing challenges with the technology at the moment, in particular the risk of scaffold thrombosis, which is greater than with metallic stents, but still it's still very small numbers. So this is a challenge for us, but we've had many challenges in the past in interventional cardiology. Remember the drug-eluting stent firestorm some years ago, and people were very worried about drug-eluting stents. Now that's been overcome, and I agree with you that in the same way we will overcome the challenges that we are currently having with bioresorbables. So we have optimism, and I reiterate your statement that we have a responsibility to the technology to make sure it is examined and used in a responsible way so we don't destroy the technology. I think that's all I need to say.
Thank you very much, John.
Thank you.
Thank you, John.